Namaste and greetings. I, Samprikta Banerjee, a researcher at IMPRI, Impact and Policy Research Institute, Prabhav एवं नीति अनुसंधान संस्थान, New Delhi, extend my warmest welcome to you all to IMPRI Web Policy Learning. Today marks the fourth and last day of Healthcare and Gender Equity Cohort 3.0, theme Advancing Systems, Structures and Policies to Address Contemporary Challenges, an online international monsoon school program, a 4-day immersive online certificate training course. This program is organized by the IMPRI Gender Impact Study Center GISC and Center for Ethics, Yenepoya University, Mangalore. This program has an excellent panel of experts who will be sharing their expertise for the duration of this program. The distinguished expert panel includes Professor Vibhuti Patel ji, Professor Linda Lane ji, Ms. Jaya Velankar ji, Dr. Padma Bhate Deosthali ji, Professor Brinelle D'Souza ji, Dr. Amar Jasani ji, Dr. Aksar Sheikh ji, Dr. Veena Vaswani ji, and Dr. Anant Bhan ji. The conveners for the program from Yenepoya University and IMPRI are Mr. Farhad Yenepoya ji, Professor Vibhuti Patel ji, Dr. Veena Vaswani ji, Dr. Manorama Bakshi ji, Dr. Swati Santosh Rane ji, Dr. Simi Mehta ji, and Dr. Arjun Kumar ji. Proceeding further, I heartily welcome you all to this course, Healthcare and Gender Equity Cohort 3.0. This program will help you all embark on a journey into the intricate relationship between health and gender, a historical tapestry woven with complexities shaping diverse gender perspectives on well-being. The transformative power of gender equality reverberates across health outcomes, fostering benefits for individuals and communities alike. Hence, this upcoming cohort of healthcare and gender equity unfolds as a crucial space for collective exploration, promising deep insights and contributions to the discourse on transformative inclusive healthcare systems. We sincerely appreciate your valuable time, energy, contributions, and deep enthusiasm for learning and discussing the nuances of healthcare and its relation to gender in detail. Thank you for your active involvement and commitment to learning and progressing. We hope that you take back a plethora of knowledge and valuable information from this course, which will effectively aid you in your respective fields, along with causing a notable improvement in your skill set. We have also shared the course outline and reading resources via email for your kind reference and perusal. Before we start today's session, I would like to announce the housekeeping rules. It is imperative that you join the meeting on time. There will be a Q&A session after each presentation. Share your questions in the Q&A box and not in the chat box. The questions must not be posted as an anonymous attendee. Ensure that your questions are precise. Refrain from making general comments in the question to save time. Without further ado, let us begin with the program. I am delighted to invite Professor Vibhuti Patel, Visiting Distinguished Professor IMPRI, for her opening remarks. Over to you, ma'am.
Yeah, thank you, Samrikta, for introducing the course and also providing the guidelines. Today, we are on the last day of our journey of an online international monsoon school program, a 4-day immersive online certificate course. I would like to express my heartfelt thanks to Dr. Anant, Dr. Arjun Kumar and Dr. Veena Vaswani for anchoring this course, and also the whole team from Yenepoya as well as IMPRI. I welcome Dr. Anant Bhan and Dr. Professor Brinelle D'Souza, who are today's expert and would just provide the recap of what transpired yesterday. We had a very provocative presentations because they dealt with the ground reality. Dr. Padma Bhate Devasthali began her presentation with a submission that gender-based violence is not the same as violence against women, because gender-based violence is a much more comprehensive in its coverage. And she also explained circles, 3 circles of outer circle, where you face violence in the society, the middle circle in the community, and internal circle, where the domestic violence she dwelt upon. And she also talked about that how, with regard to physical and mental health of the victims and survivors, who may or may not report violence, but we as conscious persons, and especially the healthcare providers, they have to be they have to walk extra mile to understand the predicament. And also she reflected on the aversion therapy and conversion therapy and showed so many controversial debates that we have had over last 50 years. She stated the gender-based violence has been one of the largest methods by which women have been killed. She also gave examples to show the limits of medical evidence in cases of sexual violence. And no medical evidence doesn't mean that sexual violence did not happen. And I think we also discussed the Mathura rape case, where there were, just because there were no bodily injuries at the time of medical examination, the judgment went against her. She put forward 3 exercises on domestic one, the episodes were about domestic violence, sterilization of a minor girl with disability, and marital rape and torture. And participants, I think all of you gave a very actively participated and gave your responses. She shared her, Dr. Padma shared her personal experiences of the processes involved in starting one-stop crisis center for the survivors of gender-based violence by Sehat in a 1,200-bedded hospital in Bandra West in Mumbai. She also showed negative implications of mandatory reporting that results in denial of services to the survivors of rape, incest, and unwanted pregnancy. She remarked that in the clinical protocols of patients' rights, along with the informed consent, we should also have a refusal, patient's right to refuse. So it must be included along with the informed consent. And also clinical responsibilities of doctors must be in the interest of care and well-being of the patients. And she also shared the link of a YouTube film in which her work was captured. Dr. Akshar Sheikh began with a crisp remark, and I quote, "What we don't understand, we fear." She dwelled deeply into transphobia, homophobia, and gender diverse LGBTQIA plus people, and phobia against them, and also response of the healthcare system. She emphasized intersectionality approach in the patient treatment, and she gave real life examples to show how gender identity of trans persons plays a major role in their exclusion from education, employment, safe space, shelter, dignified existence. And she vividly narrated agony and painful journey of intersex people in accessing health services. She stated that lack of opportunity to education results in very few livelihood options for the trans persons. They have to survive by performing batti badai and sex work and dancing and blessing. And she told about the landmark events which started with the NALSA judgment in 2014, and so many series of small battles were won, and the right to healthcare was granted to trans person. Indian Psychiatric Society issued statement against conversion therapy. And from the medical textbooks also, some of the queerphobic terms such as sodomy and lesbianism are removed. And still, stigmatization prevails. For example, there is a ban on trans persons and gay persons donating blood. The participant also shared a very valuable article on which played a pivotal role in terms of scientific opinion when the Supreme Court gave a judgment on the repeal of section 377 of IPC. At the end of her talk, Dr. Aska asked, "What can we do?" And she answered that we must act for decriminalization, depathologization, and demedicalization of gender diverse communities by changing attitudes of government and society towards gender diverse people. Not only the medical aspect, but also social aspect should be taken into consideration. And she showed photo stories of exclusion and discrimination for sensitization. She also said that there are so many other knowledge resources and the training manuals have been created by the group of doctors who are gender affirmative. And gender affirmative mental health care and competent healthcare for gender diverse people must be included in the syllabi of 706 medical colleges that India has and 5,000 nursing colleges we have in our country. And she also asked a very sharp question that are we doing research on trans people or are we doing research with trans people? The last speaker for yesterday was Dr. Swati Savantrani, who represented the interest of the nursing community, and she also began with the definition of WHO about nursing, which encompasses autonomous and collaborative care of individuals of all ages, families, groups, and communities. She said that the nurses play a critical role in healthcare and are often unsung heroes of healthcare facilities and also emergency response. She also demanded that half of the healthcare professionals in our country are nurses, and they are also now organized. They have their own association. They are often first and sometimes the only health professional and patient will see, and quality of their initial assessment and subsequent care is vital to strong health outcomes. She reflected on the abysmal work and living condition of nurses, absence of psychosocial support, sexual harassment faced by overworked nurses, and she strongly criticized the National Nursing and Midwifery Commission Bill 2023 that was introduced without consent of nurses, and she attributed ill-equipped public health sector to the very measly budgetary allocation, that means 1.9% of GDP, to the public health facilities. The very interesting discussions that followed after all three presentations, and that also gave us so much food for thought to all of us. Thank you.
Thank you so much, ma'am, for summarizing the previous day's sessions. Now I would like to invite Dr. Veena Vaswani, Professor, Department of Forensic Medicine, Director, Center for Ethics, Program Director, YUFIC, Masters in Research Ethics for India, Yenepoya, deemed to the university, for her remarks. Over to you, ma'am.
Thank you very much. Actually, after Dr. Vibhuti Madam has done such an extensive recap, there's nothing much left for me to say. Although I could say that the objectives of every speaker has been fulfilled to a great extent. There is not a cure that we can find, but the fact that we're sensitized to these things will bring in solidarity. And so, especially starting with the first presentation, when we looked at how gender-based violence takes place. So if you go on connecting with the earlier, then it's almost like funneling out into a nice story. The historical aspects, moving on to contemporary challenges, and moving on to gender-based violence in the healthcare, as well as trans care, and how we as doctors hesitate to look head on to say, we are doing wrong. We need to change. We need to introspect. So many of these points were brought out, but what I think, according to me, from all these three cohorts that we have been having, the enthusiasm of the participants is laudable. It is so good that it's making us feel that, okay, there's so much to be done, because there's a huge crowd or volunteers plus professionals who are ready to take the step forward. So with that, I conclude my remarks. Over to you, Sanskriti.
Thank you so much, ma'am, for your valuable remarks. Now, I would like to hand over to Professor Vibhuti Patel for conducting an interactive and fruitful discussion.
Yeah, I think we would like to have a feedback from our esteemed participants about how the things are going and what are the other thematic areas which you consider very important for the future courses, and also share your personal experience, because you are also directly involved in some way or the other into the healthcare, either services or your experiences with the healthcare system. You can share.
Anybody willing to share can unmute and speak. Please go ahead. Yes, Ananya ji.
Hi, good evening, everybody. So I already mentioned that I completed my master's in women's studies last year. And since then, I've been freelancing with a few NGOs, and I don't have a proper job right now. But I also felt that that there had been a gap between me and academia for quite some time now, because I was not actively studying or reading literature regarding my subjects. So this was a very, very great step for me. I believe these 4 days have been I've been rejuvenated, because I've been introduced to some subjects that I was already studying during my master's. And of course, there were a lot of new things also. One thing that I maybe the next time this happens, one thing that I think maybe which was not talked about very much was that healthcare when it comes to sex workers, maybe particularly them, because I have my main areas of interest are working with trans people and sex workers. And there was a targeted intervention that I was at last year in Delhi, and I had visited the community and I worked with the community for a few weeks. So we used to go to them, and the one thing that it was very confusing for me as well was that I used to go with the outreach workers with them into the field, and the outreach workers told me that once they always go and ask the sex workers to to visit to come to them to their offices and maybe visit the doctor with them. They could provide them medical facilities. They told me that a lot of sex workers were not very uh, very encouraged to maybe go visit the doctors. This could obviously maybe because of the way that they're treated. That is one option. That is the one idea that came to my mind. But the rest, I really could not comprehend why. Because obviously, like, sex workers need a lot of healthcare, especially because most people will not go and treat them nicely. So maybe there's a gap between how doctors are maybe not trained properly to talk to them or treat them or make them comfortable as human beings first and then as patients. So yeah, I think maybe something on that area could have helped me more. And maybe if this happens next time, I would love to attend that as well. Thank you.
Think this is a very important aspect, and we have seen that even during the pandemic, the stigma got valorized again and again, both by the mainstream media and also that Harvard University study, which also suggested that it is the locus of spread of coronavirus is going to be the red light areas, and after that the torture and the nakabandi in the red light areas, which created further marginalization, hunger among the sex workers, because no philanthropic institute was ready to even allow. If they were putting the conditionality to the relief workers that our ration kit or our ready-to-eat food packets should not be given to sex workers and transgender persons, no? So that is the level of prejudice that was generated, and the healthcare system or the doctors and nurses, they did not even stick out their neck to counter this kind of prejudicial behavior. And finally, it was the People's Health Assembly, Janaswasthya Manch, which had to file public interest litigation to see to it that they are provided with the ration kit. And also, when it came to the vaccination program or even various detection centers, they would not allow them to even enter their premises. So I think it is such a deep-rooted prejudice is there, and you are right that in the next such course, we should have a special session on stigma. So all those who are stigmatized or not, sex workers or sexual minorities, gays, and even it was also said that it is we need to see to it that the gays behave, they don't generate more problems in the midst of the pandemic, no? Because of their sexual behavior. So this kind of issues, and there are enough studies now to corroborate that these are the prejudicial way of looking at this thing. And I think Dr. Veena Vaswani, who actually provided the health services during the pandemic, she can share more. Mr. Vaswani, would you like to respond?
Yes, ma'am. I would like to respond.
Yes, yes.
because when the COVID started, it came as a surprise to everybody. And many of the doctors in Mangalore were in such a situation that more than half the faculty come from Kerala every day, and then they go back. So it literally meant that we were working with very few people because they wouldn't be coming the next day. So then on, we had to do a lot of planning as to how best we can make sure that the healthcare will go on. And similarly, what happened even with the doctors, there were very few doctors who came forward to give their support for this, because there was this fear of uncertainty, because many doctors, because of aged, this thing also had comorbid conditions. And there was a huge fear mongering that was happening in public and also at every level, where I think the scientific talking to media came much later. Initially, it was only propagation by the WhatsApp groups. The entire GAN was given by WhatsApp universities, and people lapped it up. And so at that particular time, when the healthcare was literally trying to take it in its infancy to how best to accommodate 24/7 the COVID patients, our hospital saw maximum number of patients. I don't say because I come from the hospital, but because our charges was merely 1,500 rupees per day, along with food, including fruits and the overalls that they get. So that is why there was such a huge rush that we had people coming, because my husband was the COVID nodal officer, even something like from as far as Mysore with ventilators, they used to come. So for the first time, we came to know the politics of geography, because the officers of the district were not happy that we are showing more numbers of COVID compared to others. So it was almost like a number fight, that no, you already have so many now, you can't admit anymore from there. You tell them not to come today, let them come tomorrow. Now, our hospital caters for a lot of districts, including some districts in Kerala. They come every day by train and by buses. And suddenly blocking the borders made it very tough, because they are our patients, our confirmed patients, but they are going somewhere else and they are not being seen there. So our hospital also set up a dialysis center in Kerala, and those doctors who could not come here, they were attending there, so that they could give that kind of healthcare to patients who could not cross the border and come this side. It was convenient because our doctors, some of them stayed there, and every day instead of coming, they started working in that particular place, which was taken up. A lot of things were done at a time, but I think we did not do well with transgender communities, because there wasn't much reaching out to them, because for them also it was a very shocking event. They were in some different places, and there they were ill treated. They didn't want them there, but they couldn't put them out because nobody was taking them. They couldn't travel. And in fact, the first vaccination which was given, they didn't want to go, but they literally felt like animals. They were literally dragged to the place and said, if you don't take it, then you can't stay here. We are going to put you out because you are the people who are spreading COVID and things like that. So it was one lesson that we all learned, is whatever be the condition, disease, infectious, non-infectious, long-standing, we should always be in solidarity with people. We cannot break due to fear. And that is also at the time I realized, as forensic, we failed in our duty, because our duty is mostly restricted to mortuary. And we had the dead bodies piling up. The government gave a circular that you should not hand it over. They should not have the last rites. And today I can tell you, doing last rite is a very, very important process, because it causes healing when people lose someone.
Correct.
And if you take such a shortcut to it, and especially in the first few cases, the bodies were dropped from a distance into a pit. So that was, again, it shows how inadequately trained and focused we were to deal with the humanitarian forensics at that point. Since then, I've been writing furiously about whenever things change, depending on the demands, we also need to reinvent our duty. We have to fix ourselves with more responsibility and put in our duty, even though it is not seen by others, that we have to talk to communities and say dead bodies don't transmit. And even if they're transmitting, they're not virulent enough to cause disease. There's a difference. So then there's no need to panic and run helter-skelter. Initial few bodies were even denied cremation in the village. But then where were we forensics? No, we were not talking to community. In fact, there's a term called esprit d'escalier. That means we become wise only in retrospect. So such was my condition, I could say. I felt all this I should have done before, after the event passed, as a part of reflection. So, but I think today one thing we should remember, you should never lose solidarity with people. And secondly, as healthcare services, we should not be bound by geographical boundaries. So that is one thing I wanted to say. Thank you, madam, for giving me that opportunity.
Thank you. Very, very sensitive. I think we need to have both head and heart. That's what's important. Yes, Anant.
Very true, ma'am. Very true.
Swati ji, would you like to share experiences of Janaswasthya during the and stigma, mainly stigma,
Yes.
the treatment to sex workers and transgender person from the
Okay.
perspective of nurses, nursing care? Yeah.
Yes. Basically, I got to meet transgender community after long time after COVID, not during COVID. One of the reason was that because they were not having any access to anybody who could help them. And this community was somewhere, had the fear, and because of stigma, they were not, as ma'am Vaswani rightly said, that, they were not even entitled a care which an animal could be given,
Yeah.
They were looked down so much with so much of this. And this, to be very frank, I was helping many people during COVID, but I never got any call from any transgenders, to be very frank. And we happen to have a few of our volunteers who are working with transgenders, and they when they told us the pain of them also, because there was no light, there was no food for them. Uh, they usually have access to money only if they sell their body, and that was restricted. So the main thing was that खाने पीने के लिए पैसे नहीं है, तो medications तो they couldn't even think of. So these were the words which I came to know, and that time I realized that we were talking only about people, but then transgenders are also people. So why didn't we think about them? So is this third gender so much invisible during crisis that we don't even think that they are human beings? So that was that was a big question mark which I, as a nurse, thought of, because we were fighting for everybody, but we never thought about them. And to be very frank, we were not even, I think we as health professionals are not sensitized that there is a third gender, and this third gender's needs are very different. And this third gender has its own baggages of fear. Okay, so during crisis, they are into double crisis, in fact. So that is from my side. And I think what Ma'am Vaswani said, that I think all of us should come back and write our post-pandemic experiences, because that is going to really bring richer way forward for the next policy making. That is what I think. Thank you.
But the community-based organizations and trade unions and
They help.
also
They
they were supportive.
helped.
And
They
even
helped.
when I remember when they were told, like my daughter was into relief, and when one extremely rich NGO said that our kids should not be given to sex workers and transgender people, then they said, then we don't want, please take back your truck. That was the stand my daughter had taken. And finally they relented. They said, but we want everyone's photograph. They said, sorry, we will not give you photograph. We will take a photograph from distance, and Aadhaar and this thing they had to give it, because one kit cost some 1,600 rupees. So they had to give the Aadhaar, yes. But beyond that, they said, we are not going to give you photograph. Photograph of distance we'll give, but close up and which shows their faces we will not give, because further they'll be stigmatized, and the vested interest and the local goons and all would this. And then they also ask for police protection at the time of distribution of kit.
And I think the oasis in the desert that time was the
Yeah.
civil societies, because they knew these organizations who were working, and those organizations knew them. But direct connect with the healthcare
Hospital
services
healthcare.
or the professionals, we were not, and we were not even prepared.
Even the labs, no, because the contracting was
prepared.
happened. The labs were asked to contract the RC-PCR and all that. Even they were not admitting them, no, for
Yes.
yeah.
Yes, so that is a big, I think, gap in the system, and that gap should be filled ASAP, I think. Yes.
Correct. Yeah. Even for detection, but it was Doctors Without Borders, no?
Yes.
They organized that, no? In the areas where sex workers and transgender persons were there.
I feel that in
Healthcare.
policy making, the civil society should have a big role in policy making, and now I feel that hospitals or the healthcare facilities which are now being more privatized, I think this is going to harm the transgender, because they come from the most vulnerable and marginalized class.
You should say transgender person, individual is only transgender is insulting.
Yeah.
So it should be.
So it should, they should be given their dues which are not yet been given.
Yeah.
So thank you for, taking my points here and giving me the opportunity, ma'am.
Yeah.
And thank you for even the participants. I think they are so sensitive to this issue. It's very nice to see. Thank you.
Any other feedback or any other sharing?
I have another thing to say.
Yeah, please.
So I think last year, it is a very small thing, but last year I had gone to my and she was not my gynec. I had visited a gynecologist and I had a UTI. So when she was examining me, she was asking basic questions, and then she asked me, are you, no, what did she, I think according to me, what she should have asked me was, are you sexually active? She asked me, are you married? And then I said no. And then that's where the conversation ended. And I came back and I thought, if somebody is not honest enough and they can't speak up, they will never be able to. I told that doctor, that you should have asked me this instead of that. And she said, yeah, she didn't really acknowledge that maybe she made a mistake. That's fine. It's okay. Not everybody is open to conversations like that. But that's what I thought again, where the question of sensitization comes and the point of conversation comes, that you have to talk about it initially, and then, we'll go to solving greater problems. But I was so shaken up that day that I am a 24-year-old girl and she could not ask me if I was sexually active. So again, the point of sensitization and talking about these things to doctors when they're being trained is so important.
Yeah. No, but sometimes it is also construed as a interference in their privacy, no? Because here we have seen some young girls. We have some very sympathetic gynecologist friends also who provide free service to women survivor of violence and all. And they say that even if they try to, because you believe in having rapport with the patient, you ask them, but they said these children, the young women, 17, 18, 19-year-old college girls who come for abortion, they just snap us and they say that, ma'am, do your job. I'm giving you cash. No? Don't poke your dirty nose in my matters. So it is both ways, no? Yeah,
Right.
it is both ways.
The kind of people that you meet is how you respond, maybe.
Yeah, yes.
Thank you.
Doctors come from society only. They just reflect mindset of society. Yeah. Aishwarya Rewardkar. Yes.
Vibhuti ma'am, I just wanted to tell that I have added the reading list, which I couldn't add yesterday.
Is there in the chat box or yours?
In the chat box I have added, so the
Chat box.
participants can take it. Yeah.
Chat box. I don't see in the chat box. Have you uploaded?
Yeah, I have uploaded it. Should I upload it again? Can you see it?
Yeah, because there is only one entry in chat box by AR. That's it.
1 second. I think it has gone to host and panelists.
Acha, acha, acha.
I'll just put it to everyone and I will.
If you will have to do that.
Yes.
Yes, you'll have to do it too.
I'll do it.
Yeah. For host and panelists, it is there. Yes.
Yeah. Now I put it for everyone. So,
Yeah. Well,
so just adding to Ananya's thing, I think these questions which what you are asking, we have to understand what is that the doctors come from the societies. And also it's very important is that many of the doctors are trained not to ask these questions. So again, from which college you come and what type of professors you had, whether they themselves were empowered or no, that
yeah.
also matters. And I think today's generation is very much exposed, like, you know, for a 24-year-old, it's very easy to talk, but today I'm seeing teenagers sexually active and they don't have a space to go for these questions or such gynecologists. And we don't have a system in place where, you know, where a teenager can go to any doctor. A doctor will not take the teenager, especially public health hospitals where it is free. So they will be very much looked down upon. So this gender part is, I think, still in its own nascent phase in healthcare
Yeah.
system.
I think our resource expert has also joined, Dr. Anant Bhan. So I think we can, now I request him, Samprika.
That was a wonderful discussion that followed. Now moving on with the session, I'm delighted to invite Dr. Anant Bhan, MBBS MSSC Bioethics, researcher in global health, health policy, bioethics, and mental health, mentor and principal investigator, Sangat Public Mental Health NGO, Bhopal, India, for the first session of the day on engineering healthcare system for persons with disability, physical and mental. Over to you, sir. Thank you for joining us.
Thank you so much, and a pleasure to be part of this discussion. Thank you also for
We
the
are not
invitation.
able to see your complete face. You'll have to
Yeah, I
adjust
think
your
it's
screen.
just some problem with my
Gotcha.
this child.
Yeah. Face is getting cut. Yeah.
So we just work
Now
with what we have.
now it's
It's just yeah.
better.
I think the slides are more interesting than my face. Hopefully,
Okay.
so we
Yeah.
work with this. Okay, let me try and see if my slides come on. Just give me one second.
Yeah.
So let me know if you can see the slides.
Yes.
And,
It's
yeah.
in working mode. You can make it
Yeah, I'm just putting.
slideshow.
Okay, good. So I think the idea, since you've had already a few days of very interesting presentations, is to speak about disability more specifically. And this will build on some of the work that I and colleagues in the iHair team have been doing within Sangat. Sangat is the host of iHair, and iHair is a sort of platform which brings together a lot of professionals, community members to try to look at the intersection of marginalization, health equity, access, etc. And so this work draws on that, and hopefully will give you some insights about the kind of things that we've been looking at. So the reason we need to talk about some of these issues, of course, is the fact that if you look at the data, it clearly indicates that people with disabilities are more than twice as likely to die prematurely, you know, and the average life expectancy is 10 to 20 years lesser than the general population. And if you look at subpopulations such as women with disabilities, they are almost 37% less likely to be screened for cervical cancer, as an example, and 25% less likely to be screened for breast cancer compared to their non-disabled peers, right? So within, cohorts where we already see a lack of health access relative, let's say, among women relative to men. But if you look at women within women, you will see disability among persons with disability who are women, you'll see a further decline in ability to access health services. And that is something we should remember as a metric, because that tells us something about the lack of access for persons with disability generally. Now, if you look at economic analysis, they clearly indicate that investing in health equity for persons with disabilities actually has a lot of return on investment, right? Now, as much as many of us are uncomfortable with economic metrics for investment from a health equity perspective, but if you're trying to speak to a policymaker and speak to them about why it is important to invest, in this area than just this metric that if you just invest $1, you will get a $10 return on implementing disability inclusive prevention and care for non-communicable diseases. That's a very high return on investment. And this is important because, as we were earlier pointing out also, persons with disability face a much poorer health outcome, right? And they have double the risk of developing conditions such as diabetes, stroke, or depression. And of course, as we talked about earlier as well, much lower life expectancy, which is something for us to think about. So within iHear, which is a platform which brings together academics, community members, researchers, activists, practitioners, we've been trying over the last few years to do some participatory research, advocacy, capacity building, to try to explore some of these facets and especially try to highlight the voices from the community. And what do these voices say? You know, when we have spoken to individuals who are persons with disability and try to understand the nature of health inequities that they face, then they've talked about the larger systemic issues, that how the health system is not just by itself a special sort of area where they're trying to access services, but it is a reflection of wider inequities and discrimination which they face in society. You know, a woman participant who's a wheelchair user shared with us that she was above 50, but she has not been ever able to get a gynecological checkup because the examinations tables, you know, those of you who are women or identify as women would often go to a gynecologist for a checkup. You know that there is an examination table with a particular lithotomy position, etc., which is required. Now, examination tables are designed for, a normative body, right? They're not designed for individuals who might be disabled, especially physically disabled. So they are not able to fit onto these, you know, they might not be able to climb onto that table. They might have a deformity which makes it difficult to be able to access the position which is required for a gynecological checkup. And the outcome hence is the kind you see on the slide, that this woman has never been able to have a checkup even once. And imagine what that would mean for morbidity for that person. And also the fact that most practitioners are just not trained to be able to deal with persons with disability. They don't know how to pick up a disability. They don't know how to respond to a person with disability. They sometimes don't have the tools to deal with persons with disability, right? And so this means that even with a lot of doctor shopping, if one of, you know, the first thing is, do you even have access to medical professionals? Do you have the ability to pay for these kinds of services? But even if you have all of that, let's say you come from a good socio-economic background, more privileged section of society, but even then you would be going to multiple doctors who would still not often be able to identify your disability. Now, you know, the disability, when we say disability, it's not one kind of disability. There is various ranges of disability, various kinds of disability. And so people have sometimes been shunted around without ever being able to be told what kind of a disability that they have. And that is often also because doctors are just not able to pick up, they are not trained to be able to identify disabilities. Okay? And because doctors don't give any attention, that means that disabled persons with disability also struggle with getting services which are rightfully there or entitlements which are rightly there. You know, we have a very progressive act, the RPD Act, but that requires you to have some form of certification that you have a disability. But if you're not able to get that certificate, or if the panels which are set up are again very exclusionary in the way they approach the disability certification process, then that becomes a problem by itself, right? And the fact that persons with disability often will have specific needs. Unfortunately, health systems are not designed to respond to that, and they are often clubbed with the general population, and that makes it difficult for them to again access services. And of course, the infrastructure is also not built in a way that it can respond to the needs of persons with disability. A lot of, for example, applications now, if you want to go to a big hospital like AIIMS Delhi, as you know, appointments are very difficult. So they've put in an online appointment system. But are the online platforms accessible, let's say, for someone with a visual disability, right? Or an auditory disability? Or a disability in their hand. So how will they access it without having someone available who will do it for them? And not everyone has someone available all the time, right? And even if you use third-party application like a Practo or a PharmEasy or an Apollo app, even those are not accessible, even though these are private applications. So even to go see a medical professional, to order medicines, to book appointments, it's very difficult for many individuals who are persons with disability. Plus, the one factor, as healthcare is getting more and more privatized, a lot of us depend on health insurance to access health services. Now, for most persons with disability, they have been denied health insurance, right? Whether that be a psychosocial disability, whether that be a physical disability. They are sort of excluded from access to health insurance, and that by itself also is a major cause for worry, because that excludes a large section of the population. Now, just as a reminder, almost 1/6 of the world's population has some form of disability, right? We're not talking about a very small proportion. Even if it was a small proportion, of course, we would still think from an equity perspective, their needs are very important. But, this is a very large number, right? 1 out of 6 people is not a small number by any count. And even for them, we just don't have a world which is prepared to respond to their needs. And so, parents or caregivers also struggle with this, right? So they talk about the fact that the issues which concern persons with disabilities have fallen into the crevices. And sometimes they're just basically being played almost like table tennis. They're just being shunted around. The Ministry of Health doesn't take ownership. Sometimes some services are under the Ministry of Social Justice. Sometimes it might be a third ministry which is looking at financial aid, for example, and it's often there is no effective coordination between all of that, and hence, it's extremely unfortunate that people fall within the crevices. Now, one of the things we explored in our research was, were persons with disability able to access vaccination during a public health emergency, this being COVID, right? And so we did a study called I Have Vaccine Equity, which specifically looked at this issue. And the aim was to try to understand barriers to COVID-19 vaccine access and uptake among the disability and transgender community in India, and I will and develop an equity action plan. I'll focus more on our findings with regards to the disability community. Our data was collected by one-to-one interviews and an innovative approach known as photo voice story. Some of you might have already used that. We interviewed around 24 community members, around 12 representatives of health system or civil society, and some individuals who were both. They were health system practitioners, but also persons with disability or transgender community members. So I had multiple identities. And the kind of themes which emerged were very interesting, but these are in some way not unique to vaccination. These go beyond the vaccination issue, right? So, for example, some of them talked about the fact that there was a lot of priority in the initial rollout of the vaccination to the list which was created, right? Health workers, older people, then relatively younger people, and then ultimately going down age-wise. But there was no prioritization for young people who had a disability and had multiple comorbidities, right? Now, remember, these were individuals who were probably quite susceptible to infection and to a poor outcome. So, but somehow they were lost, right? They were not considered as being important. And older people with comorbidities got prioritized, but disabled people were not part of that list, unless you were an older person, right? So that is something which is a lesson for all of us. There was also neglected vaccination centers, right? Some of these centers, for example, were on 3rd floor, 4th floor, 5th floor of hospitals without a functional lift. So if you were a person with a physical locomotor disability, how would you get it, right? Or you had to use a platform like CoWIN. Now, if you remember CoWIN, quite initially, you had to do your registration pretty quickly, and it would log you out automatically within 4 to 5 minutes if you were not able to get your slot. Now, someone who has a disability and needs more time, there was just no way to be able to provide for their needs. So they would keep trying, but perhaps not get a slot, right? And of course, the persons with disability also struggled financially and socially during the pandemic, and that was not necessarily responded to. So a lot of individuals were also individuals who had disability, but also perhaps might be persons who were gender non-binary or who are trans and were undergoing a transition. So they were not, their informational needs with regards to taking a vaccine and what impact it would have on their health was not responded to, right? So people were wondering whether they should get vaccinated or not, if their SRS is happening, if there are multiple comorbidities, should I take the vaccine? Would there be some kind of interaction which I need to worry about? But even this information was just not available anywhere, even in the FAQs which were put out, etc. Or if you wanted to speak to a person who is a health professional at the vaccination center, they would typically not know the answer with regards to the impact on disability, hormone therapy, and any other services. And this was worrisome because what then happened was that some communities were branded as being vaccine hesitant without understanding why is it that they were reluctant or what was the kind of information they needed to make up their mind. And that again tells us that before branding any community, before branding individuals as being people who are in some way opposed to the health system or to a public health need, that we need to understand why is it that they might be not supportive of that kind of an initiative. Trust was the other factor, and they talked about the fact that there was sometimes a lack of trust towards the health department or the government because they had been historically excluded from services, their needs were not responded to. So just when suddenly there was a lot of focus on getting everyone vaccinated, they were wondering, why were we forgotten for all of this while, and why suddenly is everyone so interested in getting us vaccinated, right? So it sort of was linked to the larger, longer term marginalization. So as you will see, there was a whole bunch of systemic barriers to vaccine access, inaccessibility of portals or health centers, mandatory ID requirements, transport issues. During the lockdowns, as you know, it was extremely difficult to get public transport. Ambulances were also fleecing patients. They were very expensive. Home vaccination was not available for a long time. Even if they got to a vaccination center, there was often a lack of infrastructure which would be enabling, accessible. Mistreatment was quite common as well. So that was something which was also not in working for persons with disability. So we have some publications from this research. There's a new one which has just come out this week as well in vaccine, which speaks to some of these issues. And we also disseminated the findings, not just for policymakers or researchers, but also invited community members, our advisory board, who had a lot of representation of persons with disability, and invited them to be stakeholders because this information was quite relevant to them as well. And that, I think, for all of us is something to reflect about that. We often do research with communities which are being traditionally marginalized, but how do we involve them all through the research pathway and not do it in a way that we are just collecting data from them, but in the outputs, in the sharing of the findings also, how do we involve them? Photo voice stories, as I was mentioning, was the other approach that we tried. And typically what you do is you work with communities, you support them in getting trained on taking photographs and using these photographs to tell stories, right? So it is their voice through the photos that they take, and you take them through a process of orientation planning, taking photos, discussion, and sharing. And these are the kind of photos, for example, that we got through our study, where we looked specifically at COVID vaccination and their experiences. So one of the examples was this, which was shared by Abha, who's a woman with locomotor disability, and she was talking about the fact that if there was an accessible mode of commute, then they would be able to go to the hospital. And if it is not available, then of course she could not access that. And so that was a factor in terms of taking decisions. We also developed some material which was made accessible on our website, policy briefs, community briefs in multiple languages, which was also available and accessible for persons with visual disability, etc. So using those modalities as well to share. Now, the topic for today also sort of speaks to larger health system issues, right? And how that interacts with disability. And one of the things we've been trying to understand is how accessible are our public health facilities. And so a recent project that we started is specifically going to do access audits at public health facilities in Madhya Pradesh and Goa. We are going to try to understand how accessible are these, how inclusive are these facilities for persons with disability, and how can we work with the health systems in states to make these facilities and future designs or any changes which are being planned more in line with the needs of persons with disability. And so there will be a whole set of audits which will happen in multiple institutions, drawing from guidelines which are available. Field investigators who are themselves persons with disability will go to these two states, and after training they will go and conduct these audits, and we hope to develop action plans which we will share with the health system on what needs to change in their institutions. So in terms of action research, these are the kind of things perhaps which can be done at your level. Also, some of you will belong to institutions which are interested in this area, and working with health systems, maybe rather than just problematizing, we can also talk about solutions and work towards those. The other important part for any community is, can we see people like us in the health workforce, right? When we go to a doctor, when we go to a nurse, when we go to a paramedical provider, are there people like us, who look like us, who come from the same kind of a background or identity as us? And this is where, if you look at the data around the health workforce, you will see that while there is a specified quota for persons with disability, there's actually a very low representation of persons with disability in the medical workforce, right? And this is data from undergraduate and postgraduate level in medical education, which clearly shows that it's much below what it should be in terms of the proportion of population and also in terms of the quota which is available. And this is not unique to India. Satyendra and colleagues have found that this is also true of the global north, where many persons with disability have tried to access and gone to court as well to try to address this issue, but not been able to often access training as a health provider. And this is also the case in India, as you will see in some of these cases, where persons with disability of low vision, thalassemia, hearing disabilities, schizophrenia, dysplasia, speech and language impairment, many of them were not allowed to be admitted to medical colleges or nursing colleges, etc. And they had to go to court. And in some cases, they were able to get admission, in some cases, they were not. As I was saying much earlier, the certification boards which often operate, which are the gatekeepers for deciding who gets to be called a person with disability for certification purposes, are often very exclusionary and often also don't have any representation of persons with disability. You might have a whole entire board which is deciding the percentage disability an applicant has, but that board has no member who is themselves having some form of disability. And that is a question mark as well, right? How can you understand the needs of a community when you don't have any representation in the authority which is deciding who gets to be certified or not, right? And so multiple other cases as well. Now, one aspect, of course, is also social disability, mental health disability, and how is that framed also in the ongoing narratives around mental health. And a lot of current notions of disability actually right now neglect the wide spectra of disabling experiences and conditions which specifically revolve around mental health, right? And if you look at the psychiatric model, that usually determines a standard for normal functioning that fails to account for human diversity. It often pathologizes anything that departs from the norm. And so when these individuals then try to assess individuals, then they might use certainly very outdated and stigmatizing terminology, some of which still persists in textbooks, frigidity, nymphomania, for example, earlier were terms used for women in terms of deciding what is acceptable behavior or non-acceptable sexual behavior. And similarly, there is gatekeeping for around diagnoses such as ADHD, ASD, learning disorders, and how these are also underdiagnosed among women and minority groups, right? And there is always a focus also on trying to fix the person rather than trying to understand the systemic inequalities and inequities which predict why they might be having that kind of a mental health issue. The role of trauma, poverty, abuse, sexual violence, denial of rights and freedoms, stigmatization, discrimination, and how these could relate to poor mental health outcomes, right? And also sometimes, as I was saying, not even understanding what might be the needs of individuals with a mental health disability. For example, a non-verbal autistic person might be given or prescribed speech therapy rather than understanding and observing the environmental factors and unsafety that might be contributing to their augmentative or communication needs, right? And so the response to that, and this is something that the community especially advocates for, is a social model of disability and neurodiversity that challenges the idea that you need to fix someone, right? Because doctors like to fix people, right? We like to treat people, we like to diagnose them, we like to give them treatment, and we like to bring them to our version of normality. And the social model of disability sort of discounts that and says that human neurological makeup, for example, has natural variations, and each individual might have unique ways of functioning with their unique mental health and support needs. And that's where the term neurodivergence has come in, which is an alternative to psychiatric labels like disorders, or to try to depathologize certain chronic psychiatric diagnoses like ADHD, ESD, BPD, bipolar disorder, that have sometimes been used to stigmatize individuals who might be having a mental health condition. And hence, involving more individuals who are themselves persons with lived experience in devising more inclusive terminology, inclusive responses, I think becomes important, especially when you're dealing with the disability community. And now, of course, many of us learning from colleagues and leaders within these communities are also recognizing the importance of intersectionality in trying to understand how marginalization operates, how oppression could influence mental health outcomes, and how also the provider's personal biases and assumptions also have a role to play, and how some of these conditions and disabilities could also be higher because of the violence of that individuals or communities might be undergoing, because of poverty, because of a lack of access to services, etc., and how those systemic barriers also need to be talked about. And this is where I think I would like to end by again inviting all of us to reflect on this key term which has come from the disability community. So a few years ago, I was temporarily disabled for a few months because of a leg injury for which I had to be operated. And so I had to initially use a wheelchair, then a crutch and support for a few months. And that experience of being disabled for a short period also made me realize a whole lot of things which I did not know. You know, when you're on the other side, I have been trained as a physician, but being on the other side, being a patient, being operated on, having to live a few months with a disability showed me again a totally different side of what we might not understand. And hence this term is extremely important, that whenever we are thinking about the health system, and we are thinking about any kind of public services, we need to include and respond to the needs of those who we are talking about. And hence, nothing about us without us is something which I would like to leave you as a thought. Thank you for your attention, and hopefully this gives you some examples of how there is an intersectionality approach requirement to look at disability, whether we're talking about physical disability, mental health disability, or other forms of disability and marginalization. Thank you again for the opportunity to speak to all of you.
Thank you so much for your insights and perspectives, sir. They were deeply informative and thought-provoking. I would now like to invite the chair, Professor Vibhuti Patel, for her remarks. Over to you.
Thank you, Dr. Anant Bhan, for such a thought-provoking and also insightful presentation based on personal experiences of working on this issue. And my 2-3 questions which I have in my mind is that recent debate on the misuse of disability certificate, that it will not only deny the genuine candidates their rightful opportunities, but also disrupt the hiring process for general candidates. What is your opinion about it, and what safeguards can be taken by the authorities? And the second issue is that of to create the systems and structures which are responsive to varied forms of disability. And I think you also talked about intersectionality. what kind of laws, policies, and budgetary allocations are required? Because for the first time now we have union government which gave at least 740 crore rupees for dealing mental health as an issue was acknowledged officially in the post-pandemic period, and how can we use this, because it, like Nirbhaya fund, it should not remain unused. So what is the way in which the resources can be used to create support system, and also the changing the attitude of the healthcare system and generating solidarity and empathy? Yeah.
Sure, thank you, Professor Patel. So I think these are both important questions. Taking the second one first, I think one of the things we have in this country is sometimes very progressive legislation and policies. If you look at both RPD as well as the Mental Health Care Act, they are fairly progressive. The Mental Health Care Act has a lot of language which is very rights positive. It takes a human rights approach to mental health. The challenge is implementation. We have beautiful papers and policies, but they are not really implemented on the ground. For example, there is a requirement under the Mental Health Care Act to have a state mental health authority, district mental health review boards. Many states, including the state I live in, Madhya Pradesh, have not activated this mechanism. Some of the largest states have not. Very few states have done it, right? So we have a very beautifully written law and rules, but no implementation on the ground. Yes, there has been more focus on mental health post-pandemic, which is good to see. But a lot of that funding has gone again to larger institutions, tertiary care, to the setting up of a mental health helpline, but not really changing the fundamental requirement, which is a mental health availability closer to communities. So in primary care, for example, and also addressing the issue of the stigma around mental health. Even within the medical profession, for example, there is a lot of stigma around mental health. People who are medical professionals, doctors, nurses, many of them also have mental health issues, but they are afraid to be labeled as having, for example, a mental health issue, because again, societal perceptions make them scared about that label. So I think the larger issue is, how do we change that paradigm and make mental health available in the same way non-communicable diseases now largely available? So I think that is what is required. Even with more budgetary funding, we need to recognize that the data from the National Mental Health Survey in 2016-17 shows that only 1 in 10 individuals for some forms of mental health conditions is able to access quality care on time, and 9 out of 10 are not able to, or 8 out of 10 are not able to. So that treatment gap is still fairly high, and hence a lot more needs to be done. To your first question around this whole controversy around the IAS officer who again, got caught because they were displaying their power in inverted commas. I think that some commentators have sort of twisted that to say that let's just move away from a model where there is a prioritization or representation of persons with disability, and we should not have affirmative sort of provisioning for them. And I totally disagree with that. I think this is something where the system has been rigged. And again, this goes back to the issue I spoke about a couple of times, that the mechanisms for deciding who has disability and who doesn't have disability, a lot of that is not very objective. That is very subjective, and hence it is prone to misuse, as we might have seen in this case. So the answer is actually not excluding persons with disability from having access to these opportunities. It's ensuring that we have a transparent, objective mechanism, which is also inclusive in nature, right? And which also includes persons with disability themselves as part of the assessment panels, and ensuring that these are objectively applied, so that a whole lot of individuals who are clearly eligible are able to access these kinds of affirmative provisioning, and it is not misused as we saw in this case. So I would really urge all of us to try to find mechanisms to support more inclusion, and not use that one aberrant case as a way of enabling exclusion of a very large community which has been historically marginalized.
Well, one thing that we have found is that not many states have even applied for, sent proposal to NIMHAS for creating mental health facilities within the existing hospitals, or creating a special center. So only Kerala has sent the proposals. So what can be done at a subnational level to make the administration and governance structures more responsible? Otherwise, what will happen? Money is parked in the ministry, but it will remain unutilized, and next time the budget will be scrapped.
Absolutely, I think that's true, and I see that happen certainly in many states, as you're rightly saying. So my sense is, one, of course, those of us who are researchers should be creating evidence, because policymakers need to be shown the evidence, but we also need to work with communities. When persons with mental illnesses or their caregivers are able to advocate for their rights and speak to their needs, if we can support them to do it. There, as we said, we have progressive legislation. It's just that people are not able to use them in the right way, because sometimes they are not aware of the legislation. Sometimes the mechanisms through the boards and the authorities are not set up. But through RTI, through the mechanism of maybe even PILs, etc., you might be able to push for change. Just earlier this month, as many of us will remember, was the anniversary of the Erwadi tragedy, where many persons with mental illness were burned to death because they were tied to a faith facility in Tamil Nadu many years ago. And that was a reminder of what was the condition of persons with mental illness in this country. Now, a whole lot has changed for the positive, but a whole lot still needs to change. And I think, again, making sure that we have a rights-based approach and a more well-aware set of professionals, all of those who are in this training, for example, are individuals who perhaps can take some of these messages back, can reflect on them, and think about 1 in 6 people being persons with disability, and how their needs need to be highlighted and responded to, and what kind of accountability can we take as individuals and our institutions to respond to that.
Thank you.
Thank you so much. Now, I would also like to invite Dr. Veena Vaswani for her remarks to the session. Over to you.
Good evening. It was such a wonderful erudite presentation, literally discussing the issues threadbare, the mental illness, the way one tries to look at from either the ableism lens or using the euphemisms, but not exactly pointing out to the issues that are at hand. So, but then at least the positivity of what is happening now and how it can be taken forward was clearly explained, and especially with Dr. Anant Bhan playing a leadership role in the mental health related issues and drawing attention and doing more and more research. For quite some time, although it was neglected, like when we were medical students, we read about people who were chained, who were burnt, who were ill-treated, who were discriminated. And although there was a mental health act, it did not address these issues. Today, we have come a long way, but not long enough. We haven't reached that stage where we can say satisfactorily that we are doing the right thing. But what is important is the issues which are kept constantly upfront and discussed and deliberated upon that cause a larger degree of awareness. So for that, I really thank Dr. Anant Bhan for dissecting these issues. Thank you very much. Over to you.
Thank you so much, ma'am, for your remarks. The floor is now open to questions from the audience. You can write your questions in the Q&A box or raise your hands and unmute and
Aishwarya Reval. Yeah. Doctor, yeah.
Good evening. So I follow Sangat website on social media and I always read about Sangat. So it was really great to directly listen from Dr. Anant Bhan sir. And it was very thought-provoking session. And it enlightened me in many ways, which I never thought of about disabled people. So the starting of the session about the lithotomy position for gynecological examination, that was so much eye-opening. Like as an obstetrician, I never trained like this, that how things should be different for differently able people. It was really eye-opening. I remember one incident from my post-graduation. I had a patient in labor. She was paralyzed below the waist, And I was so much concerned that how she is going to deliver and how she is going to bear the pain. But my professor just labeled her with a person with stroke in labor, and nobody took the time out to plan delivery plan for her and to train her that how we should help her and all that. So that was a very heartbreaking experience for me during post graduation. And about mental health issues, I just want to tell that yeah, no, people are still failing to understand how mental health is so much important for full performance or giving full potential in profession. And myself suffer from bipolar, and there was never a safe space to express this during my professional space. That as a woman, I'm always labeled as you are too much emotional, you are too much sentimental, and you be strong. And this bipolar is just an emotional thing and all that. Even doctors don't understand what it takes, mental toll it takes. And also psychiatrists also, I felt so much different because of my gender. I had bad experiences with psychiatrists also. Like one psychiatrist was forcing me to enroll in matrimony and to get married just to get rid of my depression. So I'm still fighting to find a safe space to express that I suffer from this disorder. And I also need I also need a patient ear to listen. So I think this is a very big battle to fight on for long income for upcoming days. So just thank you for providing this safe space.
Can we now start with Professor Brinelle's session because she has a conversation.
Sure, ma'am. So, thank you once again, sir, for joining us today. It is always a pleasure learning from you. Moving along, I'm delighted to invite Professor Brinelle D'Souza, Assistant Professor and Chairperson, Center for Health and Mental Health, School of Social Work, TISS Mumbai, for the second session of the day, Gender, Healthcare and Intersectional Vulnerabilities. Thank you for joining us, ma'am. Over to you.
Can I just share? So I just want to begin with an apology that I couldn't join the other day because of a medical emergency. And I thank the organizers, both Vibhuti and Arjun, for, accommodating me today. I'm sure you've come quite far in this course, and perhaps what I have to share is what by now you're already familiar with. But we'll try and see how to make it as engaging and relevant at this point in time. Yeah, so I'll just start screen share. How do I do this now? Slideshow.
Make it full screen. Yeah.
Yeah. Where do you do full screen? Just go.
A slideshow.
Just a moment.
Yeah. You are the other.
Will this presentable? Yes. Can you see it's full screen?
It's not full screen, but
no, ma'am. End show. Yeah, end show.
Yeah, I'll end show. Yeah, 1 minute.
Okay, just click on slideshow.
Yeah.
And it will ask from the start. Play from the start. The first one. Yeah.
Fine.
Yes.
Now, since we don't use it as often, we've also forgotten how to do it. During COVID, we were quite versatile with this. Yeah, so I have been asked to talk about gender, healthcare, and intersectional vulnerabilities. And so my presentation basically will focus on, an understanding of gender, but quickly, mostly a revision with all of you, because you've already over the last 3 or 4 days have been exploring this concept of gender. Also looking at what do we mean by healthcare and what do we mean by intersectional vulnerability. So I just want us to briefly key concepts, if any of you can basically say from your own your own academic background, from your own lived experiences, the sessions that you went through, How do you understand some of these concepts, gender, intersectionality, healthcare, and vulnerabilities? Yeah, Alicia?
Sure. Good evening, everybody. Good evening, Professor D'Souza as well. So I'm also just thinking out loud, but just going over what we've been exploring over the past couple of days, as you said, I'm really looking back at so many of, as you say, my own lived experiences
Mm-hmm.
and find exactly what intersectionality is. So yes, I may have been, treated a certain way by a doctor, but then I'm also realizing that doctor was a woman, and some of the things she said to me may have been, ingrained into her, whether she realized it or not. And for so long I was angry with her that why would she say that to me? But now, you look at the bigger picture and exactly finding the midpoint between those things, it makes you question so much, look back at things. And I just like to say it's not depressing or feeling like sorry that the world is against women and there's nowhere for us. It's not like that, but I it's sort of like putting puzzle pieces together, in a way. But then you had put one piece somewhere, but now you realize, okay, it doesn't fit there, it has to go somewhere else. So I really enjoyed that aspect of it.
Okay. Anyone else? Any of these terms, gender, which I have outlined here. Sorry, I can't.
Intersection, vulnerabilities.
Yeah. Intersectionality, vulnerabilities, even healthcare, gender.
Healthcare, yeah.
Aishwarya, you want to speak, or your hand is up from the previous comment you made?
But I would like to speak. Yeah.
Okay, please go ahead.
Recently, I've been thinking like since last 2 years, I'm thinking about a lot that how my gender made my life in this way. Like my brother had some different experiences, and just because I'm woman, I had different experiences. So
Okay.
even if I'm gynecologist, like I am higher on the in the power dynamics, but still because of my marital status, my mental health issues, and other sexuality issues, all those issues put me in a vulnerable status. And then patriarchy again, in the patriarchal system, I'm again become a vulnerable person and marginalized person. So the power play I'm trying to understand, and what
Yeah.
are the ways to find a space and to find your voice. And as a writer, I'm trying to express that voice through my writing. But when I write about sexuality in my writing, even the women give me the backlash, like why you're using such a language and why you're writing about sexuality. And then I say I'm a woman and I want to write about body, and then I'm a gynecologist also. So I feel it's my duty to write. But so in our society, so much hypocrisy is filled on, like, so this is very puzzling for me, and so many new
Okay.
learnings going on. Yeah.
Yes. So you're talking at this, you're a gynecologist. So in terms of, being a medical professional, you have a certain power and status, but how
Yeah.
that is also now being mediated by your your gender, your sexuality, your marital status,
Yes.
and these experiences can be quite disempowering. And I think what Alicia was trying to say earlier also, and which we often forget, that, yeah, we hope that women are natural allies, but women are also products of patriarchal society. So they may not necessarily, because somebody is a woman, that doesn't necessarily make them, necessarily sensitive or empowering or aware about how they are probably part of this entire, patriarchal project. Yeah. Anyone else wants to say anything?
Just I wanted to add little thing.
Yeah.
Over the years, I understood that medical system was making me a patriarchal person, because there is a hierarchy going on, and if I want to be a successful obstetrician, I need to have that loud voice and shouting and all that, the typical aggressive nature of the man. So that is also eye-opening for me.
Yeah, which I'm sure even Dr. Amar Jaisani must have, or even Jaya must have, covered that how the medical, the healthcare system, the medical system, is a very authoritarian, top-down, upper caste, system, and also extremely, in many ways, very, very hegemonic, and represents the larger power dynamics that we see in larger society, isn't it? And yeah. And that's why we had this very tragic case. I mean, all of you who are in would know it, but of Payal Tadvi, who committed suicide because of the kind of discrimination that she was experiencing because of class, because of her tribal status, and also, the intersections of all of that. Yeah, so I think I slipped the presentation slip, so I'll come back to it. So we'll move ahead now. So I just thought we can, since you all have anyway gone through the, 4 days of work. So as we see here, I'm briefly going through each of these concepts. You can see it more as a revision, and before we actually come to more of the substantive issues as to why we need to talk about, gender, healthcare, and intersectional vulnerabilities. And I'll come to that. So one is, we look at gender as socially constructed. I'm sure by now you are aware of it. What we mean by social construction, that gender is not biological, it is socially constructed. So they are socially constructed roles, behaviors, expressions, and identities of girls, women, boys, men, and gender diverse people. So, I mean, this is also what I want to emphasize, because normally when we talk about gender, very often we see gender as equal to women and men, but we don't look at gender non-conforming people, and gender people who see themselves as gender diverse. Okay, and you see that gender norms, roles, and relations vary from society to society. I don't have to tell you that you're familiar with that. And gender is hierarchical, so it's not as, and that also, is part of the reason why you see such an exercise of power, and reflects unequal relations of power. And it produces inequalities that intersect with other social and economic inequalities. So obviously, when gender intersects with other social and economic inequalities, it creates conditions of what we would say, vulnerabilities. It creates conditions of enhanced risk for certain people and communities. Okay. And gender norms and values are often upheld and reproduced in the values, legislation, education systems. So what you were saying, Aishwarya, is about how a good doctor and obstetrician should be. No, a good obstetrician shouldn't be talking so, quote unquote, what you say, openly about sexuality, should be writing in a particular manner. And we also see how religion, media, and other institutions of society also, I mean, all of them are shaping our constructions of gender. And we see the gender identity is not confined, as I said earlier, because that is very, very important. Otherwise, most of our, debates around gender, seems to naturally lean towards, unless there's a conscious effort towards people who may, people who see themselves as gender diverse, so we also need to understand that gender identity exists along a continuum and can change over a time. So today I may identify myself by a particular gender, but tomorrow or a few months down the line or a few years down the line, I may identify myself differently, and that the gender fluidity is something that we must consider in our work and in our practice, because very often the health systems, like, while we now seem to have a politically correct language about homosexuality, about and about how it's not a disorder, it's not an illness, you can still see in a lot of healthcare providers a deep sense of discomfort about dealing with, gender fluidity, or I mean, trans persons, they may still be comfortable with, but in terms of gender non-conforming people, I mean, people who may see themselves as having a gender fluid identity, the health system isn't really ready to deal with these kinds of, with people who define themselves this way. And what is important about gender is that it influences how people perceive themselves and each other, and how they interact and act. And gender is also about distribution of power and resources in a society. And we also see that when individuals and groups do not fit established gender norms, I have to be polite, I have to be, subservient, I have to have a definite gender or sexual identity, then and if I don't, and I face stigma, discriminatory practices, or social exclusion, all of which will adversely affect, people's health. And also my ability to then access, health services. And we know that gender intersects with other social positions to hamper access to healthcare. Now, this is an important term, the intersectionality term, which actually was coined by Kimberly Crenshaw, who is, a professor of law at the Columbia Law School, but a very active voice in the, women's movement. And the intersectionality is an approach rooted in Black feminist theory and practice. And it basically talks about how various social identities, so whether it's gender, in our context, caste or race or religion, sexual orientation, basically, interact to either create unique experiences of discrimination or privilege. So if I'm an upper caste woman, I'm still quite privileged than a so-called lower caste man. Or if I'm an upper caste, today being a Muslim can probably be, you'll probably be more vulnerable than even being, coming from a Dalit or a tribal background. Okay, so this is how, these identities intersect. And intersectionality says that we need to consider these social identities and how they come together. Now, normally we think that medical practice, health systems, are kind of, we don't necessarily interrogate these intersectionalities. We don't look at how they're actually operating and unfolding in the lives of our patients, or the people who are seeking health services, or even people who may not actively, but may stay back from accessing health services because of they're not sure how the system is going to approach them. And intersectionality basically argues that power and privilege, and conversely oppression and exclusion, arise from multiple distinct sources that are interconnected and co-constitutive. Okay, so this is what the intersectionality concept is all about. And when we look at intersectionality in the context of health, what are we basically saying? We are basically trying to understand that how, basically this, how do we extend or understand this, gender power dynamics and its relationship with other hierarchies of privilege or disadvantage. My experience as a Dalit woman, and a Dalit woman coming from a low-income community, is going to be far different from a Dalit woman from an upper caste, upper class community. At the same time, caste, both, whether I'm upper class or coming, from a poor, lower, from a poor family, I could still face discrimination based on the fact that I am a Dalit woman. Okay, and this, so these gender power, and we say that women often face triple disadvantage, like Dalit women based on their caste, based on gender, class, and caste. Okay, then people with disabilities, say for example, Dr. Anant Bhan had a brilliant talk that he had given you all, a lecture, and how women with disabilities, say coming from low caste backgrounds, may face quadruple disadvantage. So when these disadvantages kind of come together, it creates inequality and differential health outcomes for different people. Now, these inequities in health, we often think, okay, we have the National Health Mission, we have the National Urban Health Mission, we have services and this thing, and that if we provide these services, you know, in an efficient and so-called equitable manner, it is going to reach all people, but it doesn't happen this way. We really need to see which are the groups and which are the people that are being left behind. Okay, and therefore inequities in health must be monitored to identify critical, modifiable health system and community factors that could limit healthcare access, including caste, sexual and gender identity, religion, tribal status, and geography, etc. And monitoring health inequities, because ultimately we are talking about inequities and we are talking about rights. Okay, and therefore, if we have to reduce inequities in terms of health inequities, we have to look at how these inequities are panning out, and for that, adopting an intersectional lens becomes very, very important. So you may have maternal health services and a PHC or a sub-center or a hospital, but are these maternal health services reaching out to all women, in equitable ways? Or are there certain groups of women who may be tribal, maybe Dalit, maybe women with disabilities, maybe Muslim women, are they getting left out? Okay, so for more effective and programs, you need to monitor health inequities is essential for designing more effective programs and policies to reduce health risks among vulnerable individuals and communities. Now, this is about when we are talking about health care. So basically, we are talking about a broad range of set of services, not just, clinical care. We are looking at acute, chronic, preventive, restorative, and rehabilitative care, which are delivered in many different settings by different healthcare providers. Okay, and broadly, it encompasses access to medical services, quality of care, and even public health outcomes. And we normally talk about healthcare, or when we talk about, the right to health, we talk about it from the we talk about the AAAQ framework. Availability, how availability are healthcare services to women from various backgrounds, how, and because our focus is on and not just women, sorry, but even persons who are gender non-conforming, how available they are, how acceptable they are, how accessible they are, and what is the quality of those healthcare services. And the challenge is really to deliver healthcare to everyone, which must include the socially disadvantaged, the economically disadvantaged, and also those who are systematically marginalized. Now, we come to the term vulnerability. So when the Oxford Dictionary defines vulnerability as the quality or state of being exposed to the possibility of being attacked or harmed, either physically or emotionally. Now, and a lot of the suffering that comes from one's vulnerability not only has physical dimensions to it, but also mental, social, economic, political dimensions. And why do we use this concept of vulnerability? We use this concept of vulnerability basically to justify access to resources, and also to help define our moral and ethical obligations. No, therefore, whether it's in terms of, language around health rights, whether it's about the Constitution, whether it's about, even within the Constitution in terms of, directive principles of state policy, there is this focus on, groups that are historically marginalized, or even groups that are or communities that could be currently marginalized. How do we use that language to basically understand vulnerability? And then it's not just understanding vulnerability, but we also need to see how do we then improve access to resources and help define and help and shape our moral and ethical obligations. But also we need to understand that the concept of vulnerability can also lead to stigmatization if we are not using this term in a very what if you're using this term, sorry, in a very instrumentalist way. And we often, in a lot of health research, you will hear the term vulnerability, not even in practice. Okay, but sometimes it's not consistently defined in the context of this thing, defined in the, I mean, not consistently defined in healthcare. Now, when we're talking about vulnerability, we are basically talking about the susceptibility of certain individuals or groups who experience poorer health outcomes or greater difficulty in accessing healthcare services. And this arises from a combination of factors. Okay, and many groups could be classified as vulnerable based on their health outcomes. So if you're saying that persons with disability, women with disability, or persons with disability, face greater health risks, may have more morbidity, or you're saying that women who come from marginalized background, I mean, like say Dalit women, okay, may have lesser access to antenatal care services, or their access to various social determinants of health could also be could place them in situations of marginality. Okay, so based on health outcomes, where are they? So life expectancy for, say, the average India is 70. Okay, but if you disaggregate that data, then where are women, and where are, say, Dalit women, where are tribal women, where are Muslim women, where are women with disabilities? So this is what we are basically looking at. And I said careful application of this concept can serve to highlight our moral obligations to work towards social justice. So why are we even looking at these concepts of vulnerability, intersectionality? Is because we have to highlight, I mean, we have to foreground our obligations to work towards social justice and to justify access to resources. Now, there are also critiques of this concept of vulnerability, and I thought it was important, to lay it here, because the concept of vulnerability can also be used in a very paternalistic and oppressive manner. It can also be used to widen social control, and labeling groups as vulnerable, can also result in exclusion and stigmatization. Women in sex work, or trans persons. So we may have certain services for them, in a very instrumentalist framed in a very instrumentalist way. But the way we approach groups, almost as if we infantilize them, the way the service the way the services are conceptualized is very top down. We want to protect, and this can actually result in exclusion and stigmatization. And say women, who with disability, women who are, say, with HIV, or with others, diseases which are normally seen as stigmatizing, can also face a lot of these such exclusion and stigmatization. Another critique is centered around disempowerment from attention placed on deficits. So there's a lot of attention placed on deficits, dependency, and passivity, rather than challenges, opportunities, autonomy, and self-determination. And, inadvertently, the health system tends to focus on deficits, dependency, and passivity, instead of looking at, okay, yes, there are challenges, but what kind of opportunities we can create? How do we, strengthen autonomy and self-determination, even in people, even in the case of people with severe, limitations, like, say, women who may be going through severe mental illness, okay, or having certain health conditions which are debilitating. And we also need to exercise caution against embarking on a vulnerability reducing agenda, and basically which aims to eliminate all vulnerability. such as suffering, abnormality. I mean, Dr. Bhan was talking earlier, our own definition of what is normal and what is abnormal, deafness and disability, to create perfect human beings. So I think this is, both these three, all these 3 points which critique the concept of vulnerability is also very important as we discuss vulnerability in general and also in the context of the health system. And we need to be sensitive to the consequences of these generalizations and ensure that we are attuned to the rich diversity within populations. Health systems tend to view communities, view individual from a certain lens, a lens of, what you say, I mean, a lens of power, hegemony, a lens of, not acknowledging the diversity, not sufficiently acknowledging, I would say, the diversity and the layering that exists in society. And therefore, if we are looking at the rich diversity within populations, we will also be able to, see how this diversity can be supported and encouraged, while at the same time, the health needs are being addressed. Okay. So why do we need to understand, discuss gender, healthcare, and intersectional vulnerabilities? I just want to stop, here and again try and understand from all of you as to why do we need to look at these concepts within the context of the health system or within the context of healthcare. Yeah, Shobana?
Ma'am, good evening, ma'am.
Yeah.
Ma'am, we need to be discussing healthcare in this particular context because, firstly, it comes to me as the right thing to do. Reaching welfare and is a matter of right to people, and reaching healthcare to people is the thing that the state and its machinery should be doing with all people together. The whole ecosystem should be reaching healthcare to those who require it. And there are no two ways of looking at it. It ought to be done, ma'am. So that's the reason why it should be debated, discussed, and taken forward on a war footing.
Okay. Anyone else?
I feel as a healthcare provider, we should understand that we are serving the diverse population. So we should be accommodative for people with different needs, and we should be sensitized and trained also for providing better healthcare according to different needs of different people.
Okay. Anyone else? Yes. Anyone else wants to try? Shalini, Aarti, Ananya, Golama, Bhavi, Kamlesh.
Yeah, I can just add to it that why vulnerability is to be studied is because people are vulnerable because the system has failed to empower them. The system has failed to consider them. The system has failed to give them visibility. That's why the people are vulnerable. And therefore, we need to understand what they need. They are also part of the society. Everybody is part of the society. And we should consider everyone.
Okay.
Maybe the concept of intersectionality works in this way that, in healthcare or in any other aspect, people can't, as professionals or other people can't just use one method that serves all. And intersectionality and gender and vulnerabilities, of course, help us navigate through this problem with, well, yeah, but it helps us navigate as to how these things separate one from the other and make the process better and a smoother process for people who need access to healthcare facilities.
Okay.
And just to add to it, that it should not be a second thought, it should be ingrained at the primary level itself. Why is it a second thought?
Okay. Okay, so I mean, many of you, I mean, those of you who spoke, basically, you know, are making a case that, you know, that we need to take everyone along, and that, you know, I mean, health. I mean, you said talked about health as welfare, but and that welfare should and health therefore should be available to all, irrespective of you know, one's what you say, background or social identity. Okay, and there should not be any kind of discrimination in providing, I mean, in you know, in the way this the health system responds to people. Okay, but do you have I mean, do you have experiences? Have you seen? Have you personally experienced? Have you read? Do you know of people who have experienced? I mean, again, the previous lecture, Dr. Bhan talked to you about how you know, women with disabilities are you know, and their interactions with the health system and the kinds of issues they face. But over these 4 days, you know, how do you think the health system, you know, is real, you know, has an intersectional lens in terms of the services or it provides, or in the way it engages with various communities or individuals? Yeah, if anybody wants to speak.
Dr. Aishwarya is written in chat.
Yeah, yes, Aishwarya.
Currently, healthcare services lack that intersectionality approach. And as I'm listening to these lectures since 4 days, I understood different people are invisible for the system. We focus on the able people and straight people and the fixed normal people as per defined by society. And many different individuals are invisible for healthcare.
And we know, very good, Aishwarya. I mean, as you said, you know, the health system basically, I mean, focuses on those who are part of mainstream, okay, and as defined by you know, people in power, and I mean, and that includes medical professionals and others, as to who is, you know, mainstream and who is kind of you know, on the periphery, who is normal, who is abnormal, and things like, yeah, and you know, who and largely we have a kind of a one you know, a one size fit alls, in a very broad manner of speaking. So we have, for example, the National Rural Health Mission, you have the National Urban Health Mission, you have the Ayushman Bharat program. Now, and all of these programs, you know, talk about equity, talks about access, but even and the Ayushman Bharat program is specifically for those who meet certain you know, deprivation indicators. But even within that, who is getting, you know, who is able to get access and who is getting left out? No, is also a matter of you know, what you say is something that we should be engaging with. What happens to say homeless women? What happens to women who are involved in sex work or prostitution? How are they, you know, supposed to get access to documents? How are they supposed to get access to some of these programs? And in terms of even, you know, when services are kind of available, and you know, so yeah, so we tend to think that by virtue of, you know, using a certain language of, okay, the marginalized, the vulnerable, we are actually reaching out to people, but which to some extent will happen, but we really need to see who is getting left out. And if we really look at healthcare, health as a right, healthcare as a very important component of that right, then we really need to have, who is getting left out, and for that an intersectional lens becomes very, very important. Okay, and so ensuring health equity is very, very important in India, especially today that we are seeing. I mean, we are an unequal society, and most societies in the world are unequal. But we are also so that there's already that social inequality, and we are also seeing widening economic inequality, higher levels of poverty, and often propelled by social differentiation of caste, religion, and gender. Okay, and these differentiations also have ramification on healthcare access and overall well-being. Now, equity in healthcare provision has been something that has, is actually a common feature, a common theme running through various policy documents, beginning with the Bore committee, which a committee report, which was actually a very powerful report that that laid the foundation of India's healthcare system. Okay, and over the last 2 decades, India's health system has assumed a strong commitment to innovative policies and programs towards tackling inequalities and universalizing healthcare. So there have been efforts in that direction. The point is whether these definitions, these efforts are adequate, or what more can we still do? Now, despite renewed policy priorities, there are large concerns about the lack of affordable healthcare for various sections of the population. And I was just looking at this study, which is a national sample survey of 2017 and 18, shows that nearly 12% of respondents reported unmet healthcare needs, although this number has declined from 14 to 15. And the important question is, why is there this unmet healthcare need arising among various population groups? And we really need to see is, unless we are addressing these barriers, okay, underlying barriers that are preventing healthcare access explicitly, then our mandate of universal health coverage will be a distant. Our dream for for health for all will continue to be a distant dream. And we see that unmet healthcare need is a crucial indicator in identifying the barriers in access to healthcare, and is an important measure of inequalities and health. Okay, and it is defined as the persistence of healthcare need that has not been adequately met. And it's also a reflection of health system barriers. And what does research show? In India, research studies, have used class, caste, gender, region, religion, and age to understand group differences in health. And among them, caste, class, gender, region, you have a rich body of work on them. And often what these studies are showing is that there are 3 important factors: economic differences, social exclusion, and gender discrimination, are possible explanations for unmet need. And what do these studies show? So, that individuals of lower socioeconomic positions do not use healthcare to the same extent as the better off. Now, so this is one reality. Okay, and the other reality is you're also seeing increasing privatization of healthcare in India, and a bulk of the Indian health spending is financed by out-of-pocket money. Now, higher out-of-pocket expenditure with limited ability to pay, places a considerable financial burden and pushes family into the poverty trap. and which are these, communities which have limited ability to pay. They're often women. They're often people coming, those coming from SC/ST backgrounds, those coming, and within women, there'll be women with disabilities, psychosocial and other disabilities, so they elderly women who will face acute challenges. Okay, and many of and they will be unable to access basic healthcare services. So economic differences are definitely a key instrument for unmet need in healthcare. But what and this is also in 2018, the same national sample survey had compared with the general caste, a higher percentage of SC/STs reported financial constraints as the main reason for unmet need for treatment seeking, even from public health facilities, because you know that your public health facilities also are not, completely free. Going to a public health facility costs, and there may be many services for which you have to pay. Or even a small amount, you have to pay a significant amount, or you may even actually have to go out to access those services. Okay, but these studies have also shown that the other social determinants are caste differentiation and gender biases. Two other social determinants that shape opportunities for healthcare access. So basically, what these studies are showing that unfavorable social circumstances and discriminative practices exclude low caste women from mainstream development, including healthcare services. Okay, unequal power relations within the household and gender biases at different stages of the life cycle limit healthcare use among females based on actual utilization data. And so this is this thing. And, this thing. So there are the studies on unmet care basically say that individuals with less income are abstaining from visiting a general practitioner as cost of care continue to drive many families, especially the poor, to the medical poverty trap. But, so while there is the class angle, caste and gender-based identities within each class also intersect, which also create a distinct pattern of accessing healthcare. And the interplay of class with gender and caste, suggests a marked difference in treatment-seeking behavior. So obviously, women from poor families, but women, say, from other marginalized identities will show a difference in their treatment-seeking behavior. And now increasingly, you're seeing a small but important body of work on how religion, disability, gender, and sexual identity and stigma are also impacting access to healthcare. So this is what, basically intersectional studies that we do help focus on health, highlight intersecting statuses and identities. So how do these identities and statuses come together to create disadvantage? And we often see that people with multiple disadvantaged statuses often experience poorer health outcomes. And this is not only true of India, but it is also true of the West, where black women from poor black women will face adverse outcomes compared to white women. And so you're basically saying that multiple disadvantaged statuses often experience poorer health outcomes than those with a single disadvantaged status. Okay, and intersectional research focuses on discrimination, that emphasizing that individuals with multiple disadvantaged statuses perceive multiple forms of discrimination. Now let's look at some of this in the context of India. And we look at gender, religion, and access to health services. A lot of us, there's enough of, stereotyping about, say, Muslim women. And there are studies that basically say that utilization rates of maternal health services such as antenatal care visits, skilled birth attendance, institutional deliveries are lower among Muslim women relative to women of other religious groups. And of course, there is a difference because Muslim women from South India, definitely, have very good health-seeking behavior. And the common myths and misconception is that some of the are the religiosity of Muslim women among other social determinants like income, education, class, and parity. Now, there is this study that highlights that religious practices such as a parda play a significant role in shaping women's reluctance to access maternal services, and this is largely in the context of North India. But they also report this thing. No, so sorry, I'm not presenting this correct. So many of these studies that basically talk about how religious practices such as parda play a significant role in shaping women's reluctance to access maternal services. So basically saying that Muslim women are conservative, especially Muslim women from North India, and therefore, they're less educated, they come from poorer families, and therefore you see these, the utilization rates of maternal health services poor compared to other religious groups. Then they also report that Muslim women prefer not to access facilities with male providers, and they lack decision-making autonomy regarding their reproductive health. So these are some of the assumptions that many studies that look at utilization rates based on religion, educational status of the mother, income, that they tend to conclude. But this is a very important study. There are many such studies now emerging beyond parda. Okay, understanding the issues that Muslim women face in accessing maternal health services. And Ravi Sadhu said that there are limitations to these arguments. So he says, Muslim women's utilization patterns of maternal health services may be better explained by systemic factors such as financial barriers as to the Muslim community. Okay, why is it economically backward? And what are the structural reasons for this? The historical mistrust of government health services because of the discrimination that the community has faced, health communication disparities, and discrimination against Muslim women by healthcare professionals. I mean, Muslim women in many health settings and public health settings especially are treated, quite disrespectfully. And Ravi Sadhu says that perhaps public health researchers need to adopt a socio-political lens in explaining and contextualizing the barriers Muslim women face, okay, by belonging to an excluded, minoritized or marginalized caste and religious group in India. And these may be some of the factors that are mediating their access to maternal care. Now, looking at transgender health challenges, okay? Discrimination, despite a law, you have discrimination in India's healthcare system against, transgender people, which remains, still very high. Accessing healthcare services, even for common ailments, is traumatic for trans persons because they don't fit into traditional gender roles. So where do you go? Okay, and that becomes the very basic challenge. The stress caused by the fear of being treated unfairly. Okay, worries about abuse and administrative hurdles. Okay, and medical professionals also, can be transphobic like the larger society, and because they're largely uninformed about gender identity issues. Now, now there is this example of Saikat, a transgender individual who died following a train accident, while doctors, and this was of course sometime before the law came into being, because doctors could not decide whether to admit her to a male or a female ward. Okay, a trans gender woman, Anushri Banerjee, her name is changed, as it was gang raped by 3 men, and a public hospital refused to treat her even failing to prescribe anti-HIV medicines recommended to rape victims, despite taking a very detailed medical and in this thing. And I won't elaborate much on women with disabilities, because women with disabilities, you've already had a very good session, face different socio-cultural barriers. There are erroneous assumptions, negative attitudes, being ignored, being judged, violence, abuse, insult, impoliteness, and low health literacy. Like for many of us, working in the health sector, and we raised these issues even during the HIV pandemic. Where is the, for example, the information, is information available in Braille? How do you counsel persons with disability with hearing impairment? Okay, and these challenges continue to persist. Okay, then there are the financial challenges of poverty, unemployment, high transportation cost, and structural lack of insurance coverage, inaccessible equipment and transportation facilities. Now, many people with disabilities who are living in slums and particularly women and young girls with disabilities face so much of neglect, because it's real, and for this we really need to have community-based disability, community disability programs, because even access in slum communities with very tiny lanes, okay, becomes a huge challenge. And therefore, parents are surviving, they have to provide for their families. These are working class parents. Very often the girls are just locked in their homes while the parents go to work. Okay, and poor, that's why I'm saying poor women with disabilities face major challenges. Their infrastructure, if you have to go to a public hospital in Bombay, and I'm not talking about a private hospital, moving from one place to another is itself quite a challenge for anybody who, for people without, physical disabilities in that sense. But with persons with disabilities, it becomes even more challenging. Okay, and very often you require certification. There, there may be lack of sensitivity. There may also be, exclusionary policies from lack of understanding, underrepresentation of persons with disability in the health human workforce, and women with psychosocial disabilities. They face a lot of problems in accessing healthcare, and therefore, there is this disproportionate burden of health risks that women with disability will also face. Now, when in the context, I was a few days ago doing a presentation on looking at occupational safety and health and well-being, and most of our say mental health services, okay, these mental health services basically have an upper caste, upper class, and a Western gaze to them. And increasingly a number of people from the Dalit Bahujan community have actually been talking about the challenges they face in accessing mental health services, because most of the therapists are trained in a particular school of psychotherapy, which doesn't really understand their historical marginalization adequately, and this often leads to doctor shopping. So even in terms of how mental health services are constructed, whether these mental health, either mental health services are either biomedical, or if you're, and therapy is in public health services, therapy is almost non-existent. Okay, it's largely a biomedical model with some bit of psychosocial counseling, very basic. And in the private sector, mental health services are extremely this thing. Now, to conclude, we really need more research, from an intersectional lens, and we need, so very often we look at, when we look at gender. There's a lot of work on gender, caste, tribe. There's now an increasing body of work. Of course, the you have your large data sets like NFHS and all, which do look at religion. But we really need to, we really need to see how are we looking at, all of this from an intersectional lens, and we need more tweaking of both large data sets, quantitative studies, but also qualitative studies to understand, barriers to access, and we need an intersectional lens. We also need, intersectionality informed interventions. Let's not think that because we are healthcare providers, we are committed to people, we believe in health as a right, that we are necessarily being inclusive in the way, or we are addressing, the layered disadvantages as to why people are not able to, access healthcare. And this is beyond healthcare. Okay, because we'll also have to look at the social determinants of health. We sometimes have over and underrepresentation of dimensions of equity. So yes, we know, class is an important, there are increasing studies on caste, gender, but there are some other, dimensions which are under-researched, like religion. There's in India, there's a lot of work on rural-urban disparities, but in the issue of women with disabilities, and how do we bring in these multiple lenses, also looking at communities that are involved in either or groups of people, say, involved with certain, like for example, certain in manual scavenging or in sanitation work. What are the experiences of women who are kind of engaging in this kind, and what are the multiple disadvantages that they face, and how does this pan out in terms of access? How do we embed intersectionality into health systems and in clinical practice? Okay, because we have to. So it's also about building capacities of medical students, building capacities of nursing students, building capacities of social work students, building capacities of various, a range of healthcare providers, okay? Strengthening practice and policy from an intersectional lens. Just having a program, just having, you look at your SDG indicators. So the SDG indicators talks about women, but doesn't disaggregate in terms of women from marginalized backgrounds. Now, how are we going to address some of these gaps? Okay. Then, of course, building on research, both qualitative, quantitative, on intersectionality and health justice, but also talking about agency, rights, entitlements, and ultimately citizenship. Because, people, nobody should be left out. Like, what Dr. Bhan said, I remember when I began my work in with the HIV pandemic, we said that nothing for us without us. That was one slogan. And then I got to know it actually has it's originated in the disability movement. But what the SDG goals say, leaving no one behind. So no one no one should be left behind. And that is very, very important. Yeah, so with this, I will end the session, and we can then go ahead.
Thank you so much, ma'am, for such a wonderful session that was highly informative and very much engaging for our participants. I would now like to invite the chair, Professor Vibhuti Patel ji, for her remarks to the session. Over to you.
Thank you, Professor Brinelle, for making such a comprehensive and foolproof presentation, and also providing the macro perspective. But I would like to know that even in this neoliberal perspective and the political economy that fosters various types of marginalization and exclusion, are there any examples worth emulating, which are replicable? Can you say that? Is there any hope? Is there a
I mean, we've come a long way, and there are various examples. Work with tribal communities, work happening even with Muslim communities work happening with trans persons, and some of these are led by people from the community. I mean, I think the hope was, I think if I have to go back, is when in the HIV pandemic, when we saw persons living with HIV, women living with HIV, coming forward to advocate for rights, for justice, for access to medicines. Okay, and then you saw this happening within the sex workers community. Also, your entire sex workers movement, basically sprang up from the HIV, and it didn't remain to just a movement about access and discrimination or within the health sector, but also then for recognition as worker or as workers' rights. So it actually had a spillover effect. What you saw, the abolition of section 377. No, so that also
There's a problem of connectivity.
There's a problem of connectivity where you had the decriminalization of section 377. Again, that entire movement and struggle began in the context of public health, a public health imperative. But what would you say? As these groups, men who have sex with men, the LGBTQI group got empowered, you saw it spill, and of course, addressing, demanding access to medicines, non-discrimination at the workplace, also within the health systems. You also saw it spilling into a larger movement for decriminalization of section 377. So any kind, and there is, I mean, that would be the history of the human race. As much as you have a dark side, you also have resistance building and this thing. But I think TB survivors also have been doing a lot of advocacy work, and women with with TB who face multiple marginalizations, but who have actually gone forward to challenge. Yeah.
So knowledge is power, and I think
knowledge is power. Collective action is power. Yeah, and there are
solidarity is power.
Solidarity is power. Yeah.
Thank you. Thank you. Brilliant.
Thank you so much,
Great.
ma'am.
Yeah.
Now, I would also like to invite Dr. Reena Vaswani for her remarks. Over to you, ma'am.
That was a wonderful presentation which covered a huge canvas by Dr. Brinelle. Can you hear me?
I can hear you very well.
Yeah, sure. So when she started right with defining the gender and the social construct, and actually besides social, it's also a religious socio-economic construct that has played a long way in keeping the power inequality, because that particular you could say group that gets more power will never let go of it. So that is one of the reason one uneven playing field is beneficial to some, and they wouldn't like to lose it. And that is how the battle is always back and forth, but people would like to keep that. That is how actually you could say male at the hierarchy, higher level, and then the women, then transgender. Now I would many a times look at even women, transgender persons, so many a times women who come in the way of recognizing them. So I sometimes wonder, is it because we think our a bit of advantage over the transgender people is going to be lost if we are trying to ask for equality? So that's one thing that was. And also Dr. Brinelle brought out the vulnerability. It's very important to not just focus on vulnerability, but especially in whichever position we hold, be a social scientist or pure scientists or doctors, healthcarers or policy people, that it's good to take a representation from those who are the stakeholders, who are the ones who are going to be, for whom we are making a policy. Because there's also something called a window of vulnerability. The WOW it's called. So here, vulnerability can get into anybody at any time. And today, we have such high-end lofty ideas about ableism, which is totally a myth. And actually, we do not recognize the ability of those challenged. Sometimes it goes even beyond our abilities because they work harder, they're more consistent, they're more sincere. But considering that, supposing I make all these statements, but then I meet with an accident and I become physically disabled or challenged for that matter, then suddenly window of vulnerability shifts. So that's for each of us to believe what we are not today, we might be seen like that in the next few years. So that is why the policies have to work for each and every one and not just whose voices count. So that was nicely brought out. And also the accessibility, the healthcare access, affordability, acceptance, as well as the quality. Now, talking of the unmet needs, Dr. Brinelle also brought out that these, especially from some communities, the more the unmet needs, the huge is also a way of looking over it because they have got used to it, they have accepted it. So why now bring it into a discussion? But it's important that unmet needs have to be addressed. And when we're talking about the women with disabilities, women who are single and aged and fending for themselves, women who are caregivers who are not being paid for anything. So these are important areas on which the research also ought to be focused, because the research and what I liked better also, she brought out the quantitative part of research, and especially intersectionally informed interventions. So these are actually something that one has to reflect on. What are the takeaways from this presentation? So I really liked being a part of it. And thankfully today, Dr. Brinelle, I was able to stay and listen because many a times I have some super seniors at home and by 8 I have to spring into kitchen and then start cooking. So somehow I did stay back, and I'm thankful that I could get to listen to what you were saying. So thank you very much.
Alicia has a hand up.
Sorry, I think that's maybe by mistake. Sorry.
Okay, no problem.
Thank you so much, ma'am. The floor is now open to questions. If any of you have any questions, you can unmute and speak or raise your hand to me.
Actually, can I ask a question?
Yeah.
Or just maybe share a bit of my thoughts also a bit.
Yeah.
Professor D'Souza, you spoke about, when we look at vulnerabilities, how important it is not to stigmatize or group people, or, by identifying them by their vulnerability, we should not have a certain perspective towards them. And, I completely agree with that. And, I will admit that sometimes I find myself in that kind of thought process and I have to pull myself back. Fully accepting that I come from a lot of privilege. I live in a metro city, all of these things. So when I try to understand the challenges faced by other individuals, whether they are women, whether they have different needs, different gender identities, whatever it is, uh, how should I approach that? Of separating my identity from what is actually the fact out there.
Yeah, you're asking a question, or you're
I am actually asking for advice because I find myself in this, stuck place lots of time, and I have to very consciously pull myself back, saying
So
that
I think
don't group people together.
Yeah. Alicia, I think we can all easily fall into that trap. And I think this is something that we will, constantly have to reflect on and be aware of. So at least I think you come from a position of strength because at least you have the humility to know that this is what you're, grappling and dealing with. So I would say don't be harsh on yourself, and see and to be more conscious as to how, of the privilege. We all come from positions of privilege and we all come from positions of vulnerability. I may be Yeah, I may be in a position of privilege in one area, and in another area I could be in a position of great vulnerability or relative vulnerability. So one is it. This thing why I felt it was important to talk about this vulnerability, because sometimes we approach vulnerability. Also, most researchers, practitioners, come from a particular social standing and have a certain social capital, and then we tend to and because of that we also have certain power, and we can get very paternalistic, protective, what we call benign patriarchy when dealing with vulnerable groups. So I think we need to also be aware, even while engaging in research. Therefore, today we are talking about co-creation in terms of knowledge, but to what extent that is really possible. Is there a hierarchy? But increasingly, and that is where qualitative research came in, and today we are also talking about researching and building knowledge with marginalized communities and not on behalf of marginalized communities. So I meaning, this is what I would say. It's constantly one is, and if we believe in this feminist principle that the personal is political, then I keep interrogating my own location and standing on a whole lot of issues. And as a social work educator, we constantly have to tell, work with students and also among ourselves. How are we playing out some of these, dynamics? And so we talk about, and I think ultimately, it's not even about representation. It's not even about, it's basically what we are talking about when we use the intersectional lens is about justice, it's about rights, it's about citizenship. And how do we ensure that everyone, all those whom we are engaging with, or the health system is engaging with, okay, or in terms of how do we ensure that people have equal opportunities? What Amartya Sen basically talks about, freedoms, and the freedom to choose, the freedom to be. So how does one, and he sees health as a meta capability. Okay, because if you have health, then you're able to do many other things. Okay, and if we believe that health is a meta capability, then we need to look at health inequity from an intersectional lens, because then it means who is not able to get who is not able to what you say, get access to health services, who is vulnerable to health risks, and then where does caste, ability, age, religion, race, sexual and gender identity, all of this come into play.
Thank you, ma'am.
Yeah, you can stop sharing.
Seeing no more questions, I think we can move on.
I'll just copy the chat, the comments.
Yeah.
Thank you.
Thank you so much, ma'am,
Yeah.
for such an informative session. We look forward to having you at the IMPRI Web Policy Talk in the future.
Yeah.
Now, I'm delighted to invite Professor Vibhuti Patel ji, Distinguished Professor IMPRI, for her closing remarks, after which we shall have a feedback session by the participants.
Yeah. I think this is the overall closing remark for all the 4 days and 8 sessions. I think our main aim for this cohort 2 was, because cohort 1 was based on issues. In this, we wanted to address the meta structures and also the connecting the dots between micro, meso, and macro policies, and making structures and systems gender responsive with an overarching framework of all right-based approach rooted in political economy, entitlements of people to access healthcare services in a neoliberal macroeconomic context, sharing some of our micro success stories so that it can make us empowered to change reality in whichever field or whichever sector we are in, and bringing in the question of standard operative procedures and ethical conduct that healthcare system needs to have, and also bringing care at the center of discourse, because that has become care as an analytical category has gained major attention after the pandemic, no? Because when all economists were screaming about economies closed and we are going to be down, but that did not happen because of the care. And mostly it was unpaid care, no? All of us were cooking, caring, looking after things. Today, Dr. Brinelle D'Souza, she made such a powerful presentation in the midst of care responsibility. So I think bringing care and also linking it to the even paid care, no? Because now the whole pyramid of the population is becoming top heavy. We have a life expectancy has increased. So many elderly people are going to be there. So, and how are we going to provide care with dignity and also the human rights of the aging population? So all 4 sessions I found when Jaya, she set the tone by giving the feminist perspective on engendering healthcare systems. Dr. Amar Jesani brought in the whole gender-based division of labor that is there among the healthcare system, and he differentiated between health and healthcare and the hierarchy within the healthcare system. He also gave us 200 years of history of marginalization of traditional healers, the whole history of which is of 500 years from 13th to 18th century, and also how the modern medicine also is based on the patriarchal model of healthcare provision, and so and also brought in intersectionality. I think all 8 speakers, they were in unison when it came to intersectionality in examining the reality, examining the healthcare situation and the existential struggles of large majority of population. Professor Veena Vaswani's session on gender and climate change brought in some of the extraordinary aspects of what happens when the ecological devastation takes place, or when displacement and relocation takes place, when pandemic, the major health emergency takes place, or some of the natural disasters, which are also there because of the human activity. She brought into that aspect. Dr. Linda Lane's work on maternal health and the intersectional vulnerabilities was very robust, because she also gave examples of several continents. She shared the experiences of Africa, North America, and in India also. She has done extensive research in Odisha. She spoke about that. Dr. Padma Devastari, her personal involvement in setting up a one-stop crisis center, an extensive nearly 3 decades of work on gender-based violence, also brought a very, very sensitive and gender-responsive understanding, and also doable agenda, because all the speakers spoke about what can we do. That is in terms of research, in terms of advocacy, in terms of engendering the institutions and structures. And Dr. Aqsa Sheikh's was an extremely moving and both intellectually charged and emotionally appealing presentation on healthcare and gender, advancing system structures and policies to address the challenges of queer community. She herself, being a transgender person, and the doctor who is providing the services, came up with a very, very solid, grounded case studies, as well as the nuances of the daily existential struggle of a queer community. And today's both the sessions were excellent. Dr. Anant Bhan also brought into the fore so many neglected and the areas which were always remained in the that there was hardly any work happening on persons with disability, both mental and physical disability, and also what kind of alternatives and the systems and structures we can create. And at the most suitable presentation for a concluding session was that by Dr. Brinelle, Professor Brinelle D'Souza, where all of you have also praised it to, and I find that it's a very rewarding experience. The whole 4 days have been extremely enlightening and also empowering that we can change the situation. Another world is possible. Thank you very much.
Thank you so much, ma'am, for such wonderful remarks. Now we can move along to the feedback session, and I would request all the participants to accept the request to join in as a panelist so that they can switch on their video and give their remarks.
Yeah.
I think we can go in an alphabetical order. So,
yeah, I also need to appreciate Dr. Swati Savantrani, who also pitched in at the last moment. I was just going through the timetable and speaking, but her session was also very important because generally nurses' problems as well as their perspectives are never integrated in when it comes to healthcare services, and she brought in that newer element in this whole discourse. She was there even in cohort 1, where she spoke on the interventions of the nurses and the problems, challenges, and what kind of alternatives they have created. Thank you. Good. Yeah, here. So got reminded. Yeah.
thank you, ma'am. So we can
Yeah.
start with the feedback session.
Yeah.
I think the first one to go can be RTHG. If you are here, give your feedback to the entire course. RTHG, if you are here, we would love to have a feedback from you.
Hello. Yeah, all the sessions were very thought-provoking and very many things to learn about and to reflect on and to take forward and to do research on such topics. Thank you.
Thank you so much. I think we can move ahead to Alisha Bidliwala ji. Please give your feedback.
So I would just like to extend my thanks to organizers and to each and every person who came and spoke. It was extremely new topics, and I think maybe things that we have thought about in very disjointed ways, but to have it presented in an organized way and then explained on a very scientific level, it really helps to put things in perspective, to organize my thoughts. So for that, I thank you. And thank you to all the participants as well who were contributing and sharing their personal thoughts. That's also quite informative for me. If I have any feedback, it's only that maybe we could have done the participant introduction a little earlier, because I was not sure like how many people were on the call. If I should talk, how much to talk, all of those things. So maybe that would have helped, but that's all.
So this is, we'll keep this in mind. We'll start with participants introduction. This is day 1. First, we'll do that and then we'll go for the sessions. Good idea.
Thank you so much for your feedback. We can move on to Ananya Verma ji.
Hi. So like I mentioned earlier in the evening that I loved all of these sessions, especially my main takeaway from this session, from all of these sessions, was Dr. Aksar Sheikh's lecture on how she, as a transgender person, also dealt with a lot of problems and how she's been serving in the community. And I think the phrase that stuck with me was the last line that she gave in her presentation, which said, "Nothing about us without us," which spoke so much about inclusion and how all of us as human beings also should focus on just including everybody as pure human beings, and then taking up people as whatever, straight, gay, bisexual, and whatever tags that we would like to give people. And yeah, so I think that was the best. According to me, I enjoyed that very, very much. And again, yeah, the last thing that my feedback mainly is that, again, if this happens again, I would really love if there's a session on sex workers and how people have worked with and dealt with sex workers. I would be really interested in attending that one as well. Thank you so much.
Thank you so much for your suggestions and
Yeah,
feedback.
many doctors have worked and written also extensively.
We can move ahead to Aishwarya Rewardkar ji.
I want to thank you organizers that it was really 4 days were enriching and I get to learn many new perspectives. And beyond that, I found a space like the same thinking, like-minded people, because when we are fighting our own battles in the society, we need such kind of people who can support us by different ways. So as we said that knowledge is power, then one more thing was there, and then solidarity.
Solidarity is power. Solidarity
Yeah.
is power.
Yeah, so that really reflects on me. So really thank you for arranging this 4 days workshop, and I would like to attend more in the future. Thank you.
Thank you so much. Bhavi Palrecha ji, would you like to go next?
Hi, I would like to mention that coming from an engineering background, this has been very enlightening because coming from the biotech space, we've always focused on diagnosing and the tech and the scientific basis of things. But I think the sensitivity, the idea of inclusion, uh, thinking about all parts of the society is something that could really improve society, in the sense that the technical minds especially need to get this kind of perspective, because at the end of the day, these are people who are creating tools and services for people out there, and that was one of the big reasons I joined. Also because coming from the biotech space, I saw that there's a lot of gap between tech and policy. And so getting a lot of perspective has been very helpful. So I would like to thank all the speakers and the participants, as well as Impact and Policy Research Institute for conducting this. Thank you.
Thank you, Bhan.
Thank you so much. We can move ahead to Bolama Kariappa ji.
Right. A very good evening to everybody. It's been a very lively and interactive 4 days for me. Having heard the multiple speakers speaking from various perspectives and largely focusing on healthcare, it was fairly interactive and made me set thinking on multiple things. You see, how do we expect the world to grow when the decision makers in our patriarchal society are only men? Yeah. So this is something that we all must, think deeply about. And the various decisions that are being made on our behalf are, being made by people who really do not understand certain problems or the struggles of women's lives. And I like the way in which every one of the speakers gave personal anecdotes and made us, in a way, personalize the way in which we were able to understand these things. And rightly, like how some of the speakers mentioned, we all come from definitely a certain privileged background, because of which we have a certain advantage. And I really like to go with a hope and thought that we are going to be doing something productive. And I like the way the earlier speaker also mentioned about how women are not as represented in the IT and the tech. That is where probably, I as an educator would want to focus attention and give that equal opportunity for women as well, and get them to be a part of it, because that is empowerment. So with all the multiple challenges that we may have, the one string or the stream of just being aware or being educated opens up so many opportunities. So with that, I'd like to end on a positive note. I wish the program all success. Thank you so much.
Thank you.
Thank you so much. Ms. Bhavya Singh ji can go next.
Good evening, everyone. Am I audible?
Yeah.
First of all, I'm really glad that I attended all the 4 day session, which was really informative and thought-provoking session. Coming from the psychology honors. So first of all, like I always used to the mental health, that why it is not prioritized and all. So when I attended a session, and it was like so short, physical health is not only considered as the basic human right, uh, citizens' right. So how can we expect extremely prioritizing of the mental health? And when I was when I was interning, so I seen women that what the family usually do is that sending marrying of their girl or woman to shift the burden, because they think that marriage is the solution to all the problems. And when they come to the psychiatrist or psychologist, so mother-in-law or husband, they literally ask the psychiatrist, now can we marriage, or can we plan the child, is now can we start the some is like so conscious that yes ma'am, because they have this like to start the family, they're scared. So but like when they are not able to that they're not allowed because of the heavy dosage of medicines and all. So first of that, oh my that they do care about the family, but it is for the another reason. So that all I learned, and it also, thank you so much for sharing that. That not only knowledge is the power, but also solidarity.
Important.
Thank you so much. I think we can move ahead to Shobana Kartikeya ji.
Hello, ma'am. Yeah, good evening, everybody. It has been a privilege typically to say to be attending this program. So I came here to understand more about how gender as such works in the society, its impact on health, and those were the things I came looking for. And I was definitely not disappointed. It was amazing over the past 4 days, the kind of perspectives I gained on how gender impacts health and all that. So I would say that there was a little bit of overlap in theory when speakers were speaking, but I will also insist that the reinforcement was good for somebody who wanted to learn more. So in that sense, it was good. I enjoyed it. I particularly enjoyed the case studies that Devastali ma'am shared yesterday. In fact, I was a little disappointed that the three case studies, the last three, could not go through. So if they were discussed, but of course we were short of time, so we had to give it up. But the case studies were a beautiful way to engage with the audience, and I enjoyed that part. And I will definitely be attending more of IMPRI's programs. One more thing which stood out as compared to other programs that I have attended earlier was that the speakers spoke from their personal experiences. They spoke from their experiences in dealing with people. They were all the people out there working with in the society, dirtying their hands and trying to push gender equity as far as healthcare is concerned. So that was something that shone out throughout these sessions over the last 4 days. Thank you very much, ma'am, and thank you for giving me a chance to attend this. Thank you again.
Thank you so much for your lovely suggestions and feedback. We would move on to Shama Rao ji. Kindly give your feedback.
Hello. First of all, yes, thank you for conducting this program. And this has opened my eyes to a lot of new things. For example, like yesterday, they were mentioning about doctors using nurses as basically housemates, which I have never heard about this at all. So I've learned a lot of new things. And like about the plights of the women. Yes, it feels like we are in a bubble, and we are only focused on things within the bubbles. Like once you look outside the bubble, it feels the reality is totally different. And yeah, this is what I want to say. Thank you for conducting the sessions.
Thank you so much. So that brings us to the end of the feedback session. One more participant, Jyoti Dubeji, has written her feedback in the chat box as she had to leave to do some work. So she considered the session very much eye-opening and insightful, and she thanks all of us for conducting this session. So yeah, that brings us to the end of the feedback session. I think now we can move ahead and propose the formal vote of thanks.
Please go ahead with formal vote. Thank you.
As we come to the end of the third day of Healthcare and Gender Equity Cohort 3.0, theme Advancing Systems, Structures and Policies to Address Contemporary Challenges, an online international monsoon school program, a 4-day immersive online certificate training course organized by IMPRI and Center for Ethics, Yenepoya University, Mangalore. I, Samprikta Banerjee, researcher at IMPRI, Impacting Policy Research Institute, would like to propose a formal vote of thanks on behalf of the IMPRI Gender Impact Study Center, GISC. We are grateful to our experts for the day 4 sessions, for taking out their valuable time and for their thought-provoking insights on the topics. We thank all of our participants who have raised pertinent questions and actively participated in today's deliberation. Readings for the session have been shared in your email, and a video of the session will also be shared with you for learning. We are grateful if you're watching us later on YouTube or listening to us on our various podcasts or reading our publications. The feedback form will be shared. Kindly fill it in, and certificates will be sent to your email ID by next week. We hope you continue to join in the future to our IMPRI Web Policy Talk and Web Policy Learning. With this, we come to the end of this wonderful course. Wishing you a good evening. Thank you so much.
Even feedback form will be sent, no? And yeah, thank you, Samprita, for moderating. And feedback form will be sent by email, no?
Yes, ma'am.
Okay, sir. Yes, thank you. Thank you, Dr. Ajay.